All right, welcome back everyone. We're going to start with patient assessment, page 1191. It says childbirth is seldom an unexpected event, but there are occasions when childbirth can come an emergency. So we always want to, of course, do scene size up, take standard precautions. Gloves and eye and face protection are a minimum if delivery has already begun or it is complete. And if time allows, a gown should be used. All right, Dan, of course, your mechanism for injury, nature of illness, sometimes you will encounter pregnant patients who are not in labor, so it's important to determine the mechanism of injury or nature of illness. All right, under primary assessment, you always want to form a general impression. You want to see if the patient is in active labor or whether you have time to assess for imminent delivery and address other possible life threats. You do that by performing a rapid scan examination of the patient. Then moving on down to airway and breathing. During uncomplicated birth, life-threatening conditions involving the woman's airway and breathing are usually not an issue. However, a motor vehicle crash, an assault, or any number of medical conditions may cause a life threat to exist and sometimes result in a complicated delivery. All right, circulation, blood loss after delivery is expected, but significant bleeding is not. So you want to quickly assess for any potential life-threatening bleeding and begin treatment immediately. All right, and transport decision. If delivery is imminent, you must prepare to deliver at scene. So how do we know if a woman is about to give birth? If a woman is multigravida and she says the baby is coming, it's coming. Women who have never delivered probably do not know. Contractions are less than 2 minutes apart. When a patient tells you that when the contractions start, you need to time them. Tell the patient to tell you when they start and tell you when you get another one. So you time the contractions from the beginning of one contraction to the beginning of another contraction. And if they say they need to have a bowel movement, do not let them have a bowel movement. So if delivery is imminent, stay there. The ideal place to deliver an infant is the security of your ambulance or privacy of the mother's home. The area should be warm and private with plenty of room to move around. If delivery is not imminent, prepare the patient for transport and perform the remainder of the assessment en route to the emergency department. And again, remember, women in the second and third trimesters of pregnancy should be transported laying on their left side when possible. Why? To prevent supine hypotension syndrome. So you want to provide rapid transport for pregnant patients who have significant bleeding and pain, are hypertensive, are having a seizure, or have a altered mental status. All right, page 1192 on a history taken. You should always obtain a thorough history, which includes her expected due date, any complication that she's aware of, if she's receiving any type of prenatal care, a complete medical history, and of course her last menstrual period. All right, and then you want to obtain sample history. You want to ask questions related to prenatal care. If her water is broken, ask whether the fluid was green. Green fluid is due to meconium, which is fetal stool. The presence of meconium can indicate newborn distress, and it's possible for the fetus to aspirate meconium during delivery. Meconium is basically digestive system waste. What happens is the baby gets stressed because of lack of oxygen during labor or trauma to the mother. The baby can have a bowel movement inside the amniotic fluid, and it can be green or brown and can cause pneumonia. All right, page 1193, secondary assessment. On the physical examinations, you want to perform complete assessment of major body system as needed, with emphasis on the patient's chief complaint. If the patient is in labor, the physical examination should be focused on contractions and possible delivery. If at any point you suspect that delivery is imminent, you should check for crowning. If you do not suspect an intimate delivery and the patient reports other problems unrelated to delivery, you should not visually inspect the vaginal area. Vital signs should include pulse, respiration, skin color, temperature and conditions, and of course blood pressure. So you want to be alert for tachycardia or hypo or hypertension. Hypertension, even mildly elevated blood pressure, may indicate more serious problems. All right, under reassessment, you want to repeat the primary assessment with focus on the patient's ABCs and vaginal bleeding, particularly after delivery. And you want to obtain another set of vitals and compare them with the ones that you obtained earlier. You want to recheck interventions and treatments, see if they were effective. And communication and documentation, you provide update on the status of the woman and newborn after delivery. All right, page 1193. 3 stages of delivery. 3 stages of labor. 3 stages of labor are, number 1, dilation of the cervix. Number 2, delivery of the fetus. And 3, delivery of the placenta. This is something you should know. So right there under stages of labor, go ahead and highlight that. All right, so the first stage begins with the onset of contractions and ends when the cervix is fully dilated. The first stage is usually the longest, lasting an average of 16 hours for the first delivery. So go ahead and highlight that. The onset of labor starts with contractions. So what are the purpose of contractions? They are to dilate the cervix. And the cervix is fully dilated at 10 centimeters. Other signs of beginning of labor are the bloody show and the rupture of the amniotic sac. And also the frequency intensity of contractions and true labor increases with time. Labor is generally longer in primigravida than in multigravida. Women who experience preterm and false labor women may experience preterm or false labor, which are called Braxton Hicks contractions. These are false contractions. How do we know? There is no dilation. Some women experience a premature rupture of the membranes in which the amniotic sac ruptured too early and the fetus is not developed or ready to be born. All right, page 1194. Where it says the second stage of labor begins when the fetus begins to encounter the birth canal and ends with delivery of the newborn. That is a spontaneous birth. Go ahead and highlight that. So you want to make a good decision about helping the woman to deliver at the scene or providing transport to the hospital. Urinary contractions are usually closer together and last longer. And the peritoneum will begin to buzz significantly, and at the top of the fetus head, the top of the fetus head should begin to appear at the vaginal opening. That is called crowning. And on page 1194, where it says pressure on the rectum may make the woman feel that she needs to have a bowel movement. Under no circumstances should you let the woman sit on the toilet. Highlight that. All right, and the third stage of labor begins with the birth of the newborn and ends with delivery of placenta. This may take up to 30 minutes. All right, page 1194, normal delivery management. All right, so preparing for delivery. You want to consider delivery at scene when delivery is imminent, or a natural disaster, inclement weather, or other environmental factors making it impossible to reach the hospital. To determine if delivery is imminent, ask the patient the following questions. How long have you been pregnant? When are you due? Is this your first pregnancy? Are you having contractions? How far apart are they? How long do they last? Have you been spotting or bleeding? Has your water broke? Do you feel though you need to have a bowel movement or the need to push? All right, and also you want to help determine any potential complications. You ask these questions. Were any of your previous deliveries by C-section? Have you had problems in this or any other previous pregnancies? Do you use drugs, drink alcohol, or take any medications? Or do you know if there's a chance that you will have multiple deliveries? Also, does your physician expect any complications? All right, you want to prepare for delivery if the patient says she has to move her bowels or feel the need to push. So you want to highlight that. That is at the top of the paragraph, right below what I just read, where it says ask these questions to help determine any potential complications. And also highlight where it said do not touch the vaginal area until you have determined that delivery is imminent. So once labor has started, it cannot be slowed or stopped. Never attempt to hold the patient's legs together. And again, do not let her go to the bathroom. If your decision is to deliver on scene, remember that you are only assisting the woman's delivery. Your part is to help, guide, and support the baby as it's born. Your emergency vehicle should always be equipped with sterile emergency OB kit. All right, and under patient position, the patient's clothing should be removed or pushed up to her waist. Remember to preserve the patient's privacy as much as possible. You're going to place the patient on a firm surface that is padded with blankets, folded sheets, or towels, and you will support the head, neck, and upper back with pillows and blankets. Have her keep her legs and hips flexed with her feet flat on surface beneath her knees, with her knees spread apart, and communicate with your crew and plan who will be responsible for caring for the mother and the newborn. All right, page 1196, preparing delivery field. Number 1, put on protective face and gown. Highlight that. Also, sterile gloves. Highlight number 3. All right. And you also want to open the OB carefully so the contents remain sterile, and use sterile sheets and drapes from the OB kit to make a sterile delivery field. All right, the delivery on page 1196. Your partner should be at the patient's head to comfort, soothe, and reassure her during the delivery. Go ahead and highlight that. It is common for patients to become nauseated during delivery, and some may vomit. So you want to continually check for crowning. And let me say this, if you are getting fluids on you, you are too close. Some patients may experience precipitous labor and birth, so you want to position yourself so you can see the prenatal area at all times. Time the patient contractions. Again, the way you time contractions is you start the beginning of one and ending with the beginning of the next. Determine the frequency of the contractions. Go ahead and highlight that on top of page 1197, left-hand side. And you want to remind the patient to take quick, short breaths during each contraction, but not strain. Between contractions, encourage the patient to rest and breathe deeply through her mouth. All right, under delivering the head on page 1200. You want to observe the head as it begins to exit the vagina so you can provide support as it emerges. Place your sterile gloved hand over the emerging bony part of the head to control the delivery of the head. And continue to support the head as it rotates. Be careful that you do not poke your fingers into the newborn's eyes or into the fontanelles. All right, on 1200, you see where it talks about the unruptured amniotic sac. That means the water did not break. So you may puncture the sac with a clamp or tear it by twisting it between your fingers. And that is right hand side of 1200. Go ahead and highlight that. And also at the very bottom where it says meconium in the amniotic fluid may result in respiratory distress or airway obstruction in a newborn, highlight that. All right, the umbilical cord around the neck. Usually you can slip the cord gently over the delivered head. Go ahead and highlight that. And delivering the body. The head is the largest part of the fetus, and once it's born, the body usually delivers easily. So you want to support the head and upper body as the shoulder is delivered. But do not pull Pull the fetus from the birth canal. The newborn will be slippery and covered with white cheesy substance called Versnix cassona. All right, under post-delivery care, page 1201. If the mother is able and willing, hand the newborn to her and place the newborn on her abdomen so skin-to-skin contact can begin immediately. So you want to dry off the newborn and wrap him in a warm blanket towel. And you see that under post-delivery care, go ahead and highlight that. Also highlight where it says place the newborn on one side with the head slightly lower than the rest of the body. And also highlight where it says once the umbilical cord has stopped pulsating, clamp and cut the cord. And you want to obtain a 1-minute APGAR score, and we'll talk about that in just a minute. All right, page 1202, where it says delivery of the placenta. The placenta delivers itself usually in a few minutes of the birth canal, although it may take as long as 30 minutes. After delivery of the placenta and before transport, place a sterile pad or sanitary napkin over vagina and straighten the woman's legs. Go ahead and highlight that. That is on the last paragraph, left-hand side of page 1202. Also highlight where it says you can help slow bleeding by gently massaging the woman's abdomen with a firm, circular kneading motion. That is the last paragraph on page 1207. The following are emergency situations more than 30 minutes elapsed and the placenta has not delivered. There are more than 500 milliliters of bleeding before delivery of the placenta. And there is significant bleeding after the transport of the placenta. If one of these events occurs, transport the patient and newborn to the hospital. With that, I will be right back.